All right. Let us move on to certainly a condition that you're going to see and manage. Membranous is certainly not rare. You are going to manage plenty of membranous patients. Okay. So let's talk a bit about pathogenesis and presentation. Um, Remember that we are now identifying the autoantibody in a greater number or a greater proportion of patients with membranous nephropathy. Certainly, the most prominent autoantibody that is common in primary membranous nephropathy is the phospholipase A2 receptor antibody. Okay. There are others, and that list is growing. The second autoantibody that was described after the original paper describing PLA2R antibodies was this thrombospondin type 1 domain containing 7A antibody. That is present in roughly 10% of primary membranous nephropathy. Let's contrast what that means. What would be considered secondary membranous would be lupus membranous or membranous related to a non-steroidal or hepatitis B or syphilis. Those would all be considered secondary membranous. If you're excluding those conditions, you're left with no clear cause of the membranous nephropathy. In those, with that as your denominator, you're estimating, again, phospholipase A2 receptor antibody positive disease in 75%. Okay, 10% of this THSD7A. Okay, there is, again, a growing list of other autoantibodies that are present, and some of them have associations with malignancy more than others. Interestingly, there's also now a pretty good literature that has highlighted a good amount of literature, I should say, that highlighted the autoantibody that's most commonly present in lupus-associated membranous, this antibody targeted to exhaustin. Okay, so again, this list is growing, and again, each one of these autoantibodies has a slightly different correlation with malignancy. Notice, for instance, that this THSD7A does have a higher association risk with malignancy than PLA2R antibodies. Okay. The presentation. This is the most common cause of primary nephrotic syndrome in adults who are not of African descent. Okay, there's a lot to tease out of there. Okay, primary nephrotic syndrome means I've excluded diabetes. Diabetes is going to be your most common cause of nephrotic syndrome. I've excluded lupus, right? That's also considered a secondary nephrotic syndrome if you have nephrotic syndrome. So if I've excluded all of those conditions, I'm really left with the most common being membranous, FSGS, and minimal change disease. And then there's a racial modifier for what is most likely the cause of that presentation. And there's also an age modifier, right? Of course, if you're young, you're going to be most likely dealing with MCD. And if you're non-Black, it's an adult, you're going to be most likely statistically going to have membranous nephropathy. And if you're Black, you're going to be most likely to have FSGS. Okay. This is more common in males than females. This certainly can present with explosive onset of nephrotic syndrome, but in general has less explosive onset than minimal change in FSGS. You very commonly have hematuria. I've tried to break apart what you may have previously believed about minimal change, FSGS, and membranous nephropathy, that these nephrotic syndromes typically don't have hematuria. That's absolutely not true. Hematuria is quite common in these conditions. Occasionally, you're going to have a patient who has a presentation, not so much with explosive onset of nephrotic syndrome and edema, but they're going to have flank pain and hematuria from a acute renal vein thrombosis. So renal vein thrombosis has been described in severe nephrotic syndrome more generally, but certainly is much more common in membranous nephropathy. We've had several cases of patients presenting with this clinical picture, some of which we couldn't do a kidney biopsy because they have this new renal vein thrombosis with PE, and we diagnosed with PLA2 receptor antibody testing, and that very characteristic presentation of nephrotic syndrome with renal vein thrombosis. Okay. There is this association with cancer. However, we do not typically pursue, exhaustive testing for malignancy. We simply do age-appropriate cancer screening. Okay, you might, I don't know, you might modify your enthusiasm for testing for malignancy if, for instance, you have an autoantibody to the THSD7A, simply because that has a higher association with malignancy. But by and large, you're just sticking to age-appropriate cancer screening. Okay. There are other secondary causes of membranous. We mentioned a few. Of course, lupus is one of your most common. NSAIDs are in there. We talked about hepatitis B, especially when you have this vertical transmission with the E antigenemia. Post-renal transplantation, this is actually the most common de novo GN post-renal transplantation. Think of this as a form of rejection in a way, right? You're giving somebody a kidney from someone else. You have this risk of actually producing an antibody to this new podocyte, which you've never seen before. And this is well described, that membranous nephropathy is the most common de novo GN. That means this patient has ESRD from diabetes, right? And then now has proteinuria. They did not have membranous, right? But you biopsy them, they now have membranous post-transplantation. The same is true as a form of graft versus host disease. Okay, so in the BMT patient who develops proteinuria, they often will have membranous nephropathy. So this antibody production to podocytes, either because this is an allograft from the kidney is derived from a donor, or I have a bone marrow that's derived from a donor. This mismatch between kidney and immune system can often express itself as membranous nephropathy, interestingly. Okay. There are all these other associations to be aware of as well, including IgG4 related disease. And then we have a case of this. We have sarcoid associated membranous nephropathy. We also, you should be aware of this phenomenon of proteinuria in patients that are being treated for cystinuria, right? With these cysteine binding drugs like tiopronin, can develop proteinuria, and you biopsy them and they get membranous nephropathy. That is something that's well described. Okay.